You, Rajlakshmi, and thank you to all the participants for joining us. I think we have more members to join us today's session. So today we'll be discussing about uh, pain management, specifically using opioids. Um, I understand that most of you are interested mostly in breathlessness, but we understand that pain is very common symptom that you all will be seeing, and it is very important to manage pain from your end. And I understand from most of the case presentations that pain is not pain is mentioned as a complaint, but it is not mentioned as a point of discussion in many cases. But today we'll be focusing mostly on the pain management part. And today we have Dr. Sanghamitra as our faculty. So Dr. Sanghamitra is a lead palliative care in Assam Cancer Care Foundation. And she has done her MSc in palliative medicine from Cardiff University, UK. And she's also associated with a hospice called Adjivan Healthcare Foundation. She's also a faculty member for IAPC programs and training programs with NHSRC, which is under Ministry of Health and Family Welfare. And she's been with us as faculty and in many other capacity for quite a long time now. Thank you, Sanghamitra, for joining us for today's session. So we are going to talk to a group of pulmonologists today, like last season, last year. Thank you so much.
Thank you, Sri Devi, and thank you, Rajlakshmi, for having me once again. The more I talk about these topics, I get to learn more. So it's actually my privilege. I would consider this as my privilege. So I'm going into a little bit of detail today because I understand, that as Sri Devi said, that pain is a little, a bit of a topic which is not really discussed amongst few fraternity people. And but then, everything culminates into pain. You're even a breathlessness person would actually complain of pain at one point of time. So I want to share my screen now and let me know if that is okay. So can you see my screen?
Yes, ma'am. Slideshow.
Yes.
Yes, can be seen.
Yes, ma'am. Perfect.
Okay. All right. So we discuss a little bit about the definition of pain, some little bit of pathophysiology, how pain is being transmitted, then how we assess pain, and definitely the management of pain, mainly focusing on the use of opioids like morphine and fentanyl. And then something which everybody would, as pulmonologists, would like to know about pain in respiratory illnesses and the existing evidence that supports the use of opioids. So please let me know if you have covered any of these, okay? So let me know so that I can skip that slide and then we can go ahead. So this ISP definition of pain has been revised in 2020, and it is an unpleasant sensory and emotional experience which is associated with or resembling that associated with actual or potential tissue damage. So the new thing that has been considered or included in this particular revised definition is the resemblance of the association of this particular experience, which is an unpleasant sensory and emotional experience. So now, we know that pain is an unpleasant bodily sensation, and it has an experience threat associated with this particular sensation. And this threat actually gives way to a negative emotion on a person. So pain pathophysiology, if you look at the historical perspective, it's a very simple diagram which was developed in the 1600s, and it was developed by a Frenchman, and was first published in the 1664. So, but the main anatomy that we are interested in is the anatomic areas of pain modulation, because once you understand, how pain starts and, how it is transmitted and modulated and the signals being sent back. So you know where to, cut short this particular modulation or where to modify them. So mainly, if you can see, there is a pain source. There's a hand on the left-hand side. The hand is experiencing some kind of an insult, and that's a noxious stimuli, which will actually initiate some acute physiological pain. And this will be actually carried by, the peripheral nerves to the dorsal root ganglion. But, this happens because of stimulation of nociceptors. And then, this message would travel via the spinothalamic tract, the ascending pathway. It will be processed in the, cortex of the brain, and then inhibitory signals would be transmitted back to that particular, area through the descending tracts. So this is a kind of a very simple kind of a phenomena that I'm trying to make you understand. So there are certain neurophysiological consequences also which takes place along with this transmission, and these are peripheral sensitization, peripheral recruitment, central sensitization, and central recruitment. So what happens in peripheral sensitization is that there is an insult, and the nociceptors, or the receptors responsible for perception of pain, they are sensitized in the periphery. And there is a release of certain mediators, which we called as analgesic mediators. And these mediators are mainly the prostaglandins, the potassium ions, histamines, leukotrienes, bradykinin, substance P, etc. So these are released in that particular area where the insult happens. And basically, the prostaglandin will sensitize nerve endings so that other mediators that are present there or that are produced in that particular area, they can cause a progression of the nociception. So now the learning point in this particular slide is that if we treat, the peripheral sensitization, the pain that has occurred at this particular point of time, there will be a prevention of progression of nociception, okay, from other brain producing substances. So NSAIDs as such are known to, known to prevent nociception at this point of time. So secondly, another phenomenon that progresses if we do not treat the pain by at the point of peripheral sensitization is called the peripheral recruitment. So what happens? The insult, it continues, and there will be peripheral sensitization. And at one point of time, there will be certain nociceptors, they are present in that particular area of the stimulus, but they are silent or they are sleepy. Okay, they do not generally they are not activated at all. But when there are inflamed tissues in and around, they get activated. So the pain producing substances, they recruit these nociceptors, which are called the silent or sleepy nociceptors, and the activity is actually, taken forward because of the presence of inflamed tissues. So both mechanisms of peripheral sensitization and recruitment, they can be triggered and maintained by the release of these substances in the periphery from the nociceptive terminals. So what happens if pain, the insult continues, the pain is not treated? What happens then? So this, the phenomenon called central sensitization. That means it, the pain is now transmitted continuously. The signals are being transmitted continuously to the central nervous system. Okay, so the CNS is sensitized by the nociceptive inputs. It causes a repeated C fiber stimulation, and the C fibers are generally responsible for a delayed and dull kind of a pain. Okay, so the pain actually becomes a chronic kind of a pain. So there is a progressive increase in the number of electrical discharges when there is a repeated C fiber stimulation, and that leads to sensitization of the whole nervous system, which we call as a wind-up phenomena. So the basic thing here is that if we do not treat the pain right at the point of insult, it goes on to become, sensitized in the peripheral area. And then if we do not treat that also, it actually moves up to the central nervous system and involves the whole central nervous system. The central nervous system becomes sensitized to a minor amount of insult in the periphery. And even if that is not treated, it there is a recruitment of the whole nervous system, which generally follows from the pain being left untreated, and then the result of all these changes leads to a phenomenon called a secondary hyperalgesia. And this is an increase in the sensitivity of pain perception when a noxious stimuli is delivered to a region surrounding but not including the zone of injury. So, a small kind of a sense, for example, a simple touch also produces immense amount of pain, even if the patient has had good pain medications at this point of time. So this is called the central recruitment. So based on this, we can broadly classify pain into acute and chronic pain. Acute pain is a symptom, whereas chronic pain is a disease. And when I say acute pain, it is pain till 3 months with a history of 3 months, and chronic would be more than 6 months of duration. Acute pain has a positive effect on the, as a symptom, it has a positive effect. For example, it gives a signal of the underlying disease, which can be treated. And if we treat that, the pain is gone. But when it becomes chronic, it is already, and it has a negative effect on the person. Acute pain shows certain kind of signs like pupillary dilatation, sweating, increased blood pressure, tachypnea, tachycardia, etc. But chronic pain actually leads to a decreased quality of life, including sleep disturbance, anorexia, displeasure in life, anxiety, etc., etc. Yeah. So when we talk about the types of chronic pain, basically we divide it into 2 parts. The nociceptive part is the one which involves the insult and the nociceptors. Okay, that is the nociception, and those involving the peripheral nerve and the dorsal horn, and also beyond that is known as the neuropathic pain. It is as simple as that, because it actually denotes the involvement of the nerve and involvement of the receptors. Sorry. Yeah. So nociceptive pain can again be divided into visceral and somatic pains. We can say visceral pains are those of involving capsular organs, like the liver capsule pain. The pain which, suppose you have a liver enlargement, and the pain experienced by the patient because of the stretching of the capsule of the liver, that is called a visceral capsular pain, and it is a nociceptive pain. Similarly, the hollow viscous, for example, the bowel, the obstruction in the bowel leads to pain, which is visceral nociceptive pain. And similarly, cardiac pain is also a nociceptive pain. On the other hand, the bone pain, soft tissue pain, etc., actually comes under the somatic component of nociceptive pain. On the other hand, as you can actually relate, neuropathic pain actually occurs due to nerve compression or nerve injury, and they can be divided into those of the peripheral nervous system, sympathetic nerves, and the central nervous system. So pain generally manifests as a burning sensation, pricking sensation. The patient will actually come and tell you, this is what is happening to me. I feel like a number of needles pricking on my skin or my organ. There would be a certain dermatomal or neural distribution. For example, in herpes simplex infection, you have a herpes pain, which is extremely difficult to explain and to treat also. And then there is manifestations of hyperalgesia and allodynia. So this is the reason why, in order to treat pain, we must know how to assess it. So pain assessment is extremely important, and the principle that you should always follow is that you have to review the pain every day, every minute that you are with the patient, till the patient has a baseline management of the pain. So you review, and review. But then how do you assess it? So we have, you take a general history of the pain, and, as we did in our, for other patients also. So history of the pain, and then examining the area of the pain, and the general examination along with that. And if you need to do any kind of investigation to go deeper into it, you can definitely suggest investigations also. Now, history of pain, we have a mnemonic which is very helpful for us, and it is O, P, Q, R, S, and T. So O stands for occurrence or frequency of the pain. How many times in a day? Is it a single occurrence, or does it repeat all by itself in a day or in 24 hours? And then P stands for precipitating or provoking factors, what increases the pain, and palliating or relieving factors, what relieves the pain, sleeping or lying down, using some medication, or maybe some kind of physiotherapy or hot fomentation. These are the relieving factors. Then the quality of pain, what kind of pain it is, how is the patient describing the pain, the character of the pain. As I said, kind of burning sensation, pricking sensation. Patients actually give you certain, a lot of description of their pain. They have their own description. I remember one of my patients, she was a housemaid and she came from Bihar, and she used to tell me, "Mujhe meetha meetha dard hota hai." It feels like, you would actually, at that point of time, I didn't have any kind of a, palliative care training. And I used to actually mock her. Kaise bol rahi hai, meetha meetha dard? But actually the patient is giving you the right kind of information. It is upon your, senses or your acumen to pick up that particular clue from that, from the description of the pain that the patient is giving to you. Then R stands for radiation of pain. S stands for the site or area of the pain, where the pain has started. And then the severity or intensity of pain, and then the duration of pain. Now, we need to, understand what quality of pain would represent the type of pain. So basically, wound-like, aching, or gripping sensations generally refer to nociceptive pains. And neuropathic pain or pains related to nerve compression or nervous injury would actually, be described as numbness or lancerating shooting pain, or the skin feeling like raw, chilies being rubbed, burning sensation, a bag of worms, crawling of ants. So if you can, divide correctly the description given by the patient, you can actually pinpoint the type of pain that the patient is going through. At the same time, we need to understand how intense the pain is for these patients. So we have, validated tools for, measuring the intensity of the pain, and always believe the patient about the description of his or her pain. And this is because the patient is supposed to be the best judge of his pain. He's the one who will actually give you the correct description of his pain. So these are the pain assessment tools that we have. We have a finger score, we have a faces score, and we have a number score. So basically, you all know about the NRS scale, or the numerical rating scale, which starts from 0 and ends at 10. From 0 to 0 is considered to be no pain, and 10 is considered to be the worst possible pain. Pain from 1 to 3 is considered to be a mild pain. 4 to 7 is considered to be a moderate pain. 8, 9, and 10 are considered to be the severe form of pain. So in children, we use the FACES score, and children are very intelligent when they pinpoint, the faces that, they want to verbalize, they want to actually let you know what kind of pain they are going through by pinpointing the faces. And at the same time, if there are patients who may not understand or may not correctly point out this number, so they can actually give you a correct information by using the 5-finger score. I have also used coins. For example, I ask patients that मेरे पास 1 रुपया है, I have 1 rupee, and 1 रुपया में आपको कितना पैसा दर्द है. Then the patient actually tells you कि मुझे 1 रुपया में 90 पैसा का दर्द है. So it is 90%. So you can design your own tools, and that will give you all the information about the pain. We also use body charts because patient can actually, tell you correctly कि कहाँ पे दर्द हो रहा है, where is the pain located, they can actually give you. And at the same time, you can have a proper, idea whether it is a referred pain or, you can actually assimilate the information given, on the NRS scale or the FACES scale, and then try to correlate everything on the body chart also. So now I come to the main part of the whole thing, which is pain management. So as a basic principle, always look for the cause of the pain. If it is, if it is cancer, then you need to treat the cancer, okay? And if it is a broken leg, we need to fix that particular thing. So correct the correctable. If it is radiation-induced pain, we need to correct, perhaps lower the dose of radiation. If it is chemotherapy, if it is surgery, or any other correctable causes that we can look for. So basically, the principles are prompt treatment. We need to treat pains in order to prevent the recurrence of pain, okay? And at the same time, let us also set realistic goals. For example, the patient has not slept for a month because of the pain. So are we able to, treat the pain so that the patient is able to have a good night's sleep, okay? By the clock, by the mouth, and by the ladder. I'll come to that in my next slides. And individual centered. For example, pain management, symptom management are always tailor-made, okay? Every individual will have different kind of, situations, different kind of queries, different kind of manifestations, and different kind of associated dysfunctions. For example, if you have a patient who has peptic ulcer, you need to be concerned about that and choose your pain medications rightly so that you do not worsen peptic ulcer. Similarly, with renal and hepatic dysfunctions also. And then we must not forget something called the adjuvant drugs also. So coming to the treatment, basically, we generally in palliative care start from the non-pharmacological methods. Non-pharmacological methods of pain management, or for that reason, any other symptoms, have a large role to play. Even if they do not have, do not play the major part, they will actually, set a platform where pharmacological methods can act very nicely. Sorry. There are interventional techniques also of pain management, and we generally do a mix and match of all these three modes of treatment when we take care of complex pain mechanisms. So I'm not going into much details about the non-pharmacological methods because, might be knowing about many things: heat application, cold, TENS, distraction techniques, physiotherapy, etc., etc. But I'll come to the important part of usage of pain medications by using the WHO analgesic ladder. As you can see, there are 3 steps in this analgesic ladder. So step 1 is basically meant for mild pain, which in the NRS is from 1 to 3. And so we use paracetamol, acetaminophen, or NSAIDs. Paracetamol or acetaminophen, but both of them are the same. We use either paracetamol or we use NSAIDs, okay? And in step 2, step 2 is for mild, moderate pain. mild to moderate pain, and that would be around 4 to 7. Okay, and for that here in step 2, we introduce the mild opioids, the weaker opioids, and I'll come to the weaker opioids in the next slide. And then steps 3, which is a severe form of a pain, from 8 to 10, we use the strong opioids like morphine. But having said this, step 1 could be inclusion can be included in step 2 also. For example, you use paracetamol and you see that the patient is not responding to it, so you jump off to step 2. But you do not actually cut off paracetamol. You actually continue with paracetamol and you start with step 2 medications also. Similarly, if you are prescribing a strong opioid for severe pain, you can actually continue with non-opioid. But you cannot actually combine 2 medications from step 2 and step 3. So a weaker opioid is never in combination with a strong opioid. That is a rule. You have to keep that thing in mind, because the mild opioid is of no use in presence of a strong opioid. So these are certain rules that you need to remember. At the same time, you can see that you have to remember to prescribe a laxative. Okay, this is because of the universal side effect of opioids of creating constipation or promoting constipation, unless the patient is suffering from diarrhea. Okay, so step 1, step 2, and step 3. At the same time, we need to use certain adjuvant drugs. Adjuvant drugs are very, very important because they help in taking care of the pain in many instances. For example, if you have a patient with bone pain, and the bone pain generally responds to NSAIDs, okay? But part of the bone pain is being taken care with NSAID. But if you add a steroid to it, it actually responds 100%, okay? So there are other adjuvant drugs. I mean, if I have to take, a little bit more in expansion of the WHO analgesic ladder, it will take another class, but I'm sure that you have understood the importance of adjuvant drugs in this particular area. So the use of WHO analgesic ladder also is, you have to follow the rule of by the mouth, by the clock, and by the ladder. That means that you have to use oral medications as much as possible, and have to be, around the clock medication for the patient. That is important because you need to cut off the pain cycle and follow the steps, follow the rules that has been set up in the WHO analgesic ladder. So these are the drugs that we have. In non-opioids, there are paracetamol, ibuprofen, diclofenac, meloxicam, naproxen, etc. Weak opioids are mainly that we use are tramadol, codeine, hydrocodone, tapentadol also. Strong opioids that are available in India are morphine, fentanyl, buprenorphine, and methadone. We do not have oxycodone in India. And these are the adjuvant drugs that I was talking about, which are antiemetics. Something which is, stopping the vomiting from occurring is also aiding in pain management. Antidepressants, anticonvulsants, muscle relaxants, antispasmodics, they are actually not pain medication, but they are helping relieve the pain of that person. Corticosteroids, we use a lot of corticosteroids, mainly dexamethasone in palliative care. Anxiolytics, sedatives, antacids, antacids, PPIs, bisphosphonates, antibiotics, they are also adjuvant drugs, something which is helping the main pain medications to take care of the pain. So I will now first come to the first two steps of the ladder, which are the non-opioids for mild pain and opioids plus minus adjuvant plus minus non-opioids for mild to moderate pain. So talking about the first step, which are the NSAIDs, many of our patients actually would be benefited by NSAIDs. And that is because, as we saw in the first few slides, I think the first third of second slide, I think I showed you about the peripheral sensitization. Peripheral sensitization can be taken care of by use of NSAIDs, by judicious use of NSAIDs. And that can actually prevent a pain becoming chronic. So there are a number of NSAIDs available with us, but we really do not know, or maybe we have not gone deeper into which one to use. So the main rule that you should always consider is that somatic nociceptive pain of mild to moderate intensity will properly respond to the NSAIDs. Any kind of inflammatory pain will definitely respond to NSAIDs. Bone pain in cancer responds very properly to NSAIDs. But we need to have some precautions here. We need to understand that NSAIDs like aspirin will actually cause irreversible platelet dysfunction leading to bleeding. So be careful about using aspirin. Classical NSAIDs, except diclofenac sodium, they cause a reversible platelet function, and the coxibs generally do not have any effect on platelets. So this one particular rule, you should always remember. Secondly, what is the effect on the heart? NSAIDs generally cause worsening of the heart failure, increase in the risk of recurrent MI in patients with CAD. They also worsen blood pressure, and the classic NSAID that we can use in presence of a heart disease is naproxen. So naproxen is a great NSAID for patients with heart disease. Thirdly, kidneys. Unfortunately, the kidneys are really not liked by NSAIDs. They all cause sodium and water retention and reabsorption of potassium, leading to hyperkalemia and increased blood pressure. So in presence of kidney diseases, NSAIDs are a no-no. And then coming to GIT, there's an increased risk of GI bleeding when we use with warfarin, peptic ulcer disease when we use it glucocorticoids. So we'll have to cover up if we are using in presence of peptic ulcer. We cannot use NSAIDs in the first place. But if if there is no evidence of peptic ulcer, we have to use if you are using steroids, then we have to give a double dose of PPIs. The single dose is not going to work. So tramadol, coming to tramadol, it is associated with seizures, when the total daily dose exceeds 400 milligrams. So the recommended daily dose of tramadol is 400 milligram, okay, in divided doses or in sustained releases also. It is used concurrently with other medications, for example, the tricyclic antidepressants, the SSRIs, antipsychotics, and other opioids. So we need to be very careful because these group of medications generally lower the seizure threshold. Rapid IV injection of tramadol can actually precipitate seizures in people who have had a history of such episodes in the past. So while you take the history of a person, while you decide on using the step two drug, which is tramadol, be careful about using it in a rapid IV injection. It can also, precipitate seizures in epilepsy, head trauma, and raised ICT. If we compare the potency ratio of other medications, step 2 drugs and the step 3 drugs with morphine, then you can see that tramadol, codeine, and dextropropoxyphene, they have a potency of 1/10 to that of morphine. On the other hand, methadone, buprenorphine, fentanyl, they have a increasing potency. The highest being that of fentanyl, which is 100 to 150. I'm talking about the opioid potency because sometimes you will need to stop morphine and give another medication, for example, fentanyl. So at that point of time, the transfer ratio needs to be considered, but the potency ratio needs to be considered. So how do we introduce strong opioids for ongoing pain? So the indications are mainly pain, which is unrelieved by non-opioid analgesics, and the starting dose generally depends on previous opioid exposure, the age of the person, and the severity of pain, definitely the severity of pain. And always remember that that continuous pain generally requires continuous or a background of analgesia. It cannot be SOS. It has to be continuous. So this is the beautiful flower that, from which we get morphine. It is called the poppy flower. You can see on the middle picture, it is the unripe capsule and a white gummy, liquid that is being extracted, and those this particular liquid is then dried, and morphine is synthesized from this. Interestingly, morphine is the only drug which is synthesized from a vegetable source. That is quite interesting. And the whole plant, which is called the Papaver somniferum, the whole plant actually produces morphine. It can be used for synthesizing morphine. So, oral route morphine formulations can be given by oral route. There are slow release morphine also. It can be given subcutaneous or IV route also. So it's a weak base. So it is readily absorbed orally. Basically absorbed in the upper small bowel very nicely, because that particular part of the body has an alkaline medium, and since it is hydrophilic, it has a slow onset and a longer duration of action. Sublingual absorption is extremely low. In fact, there is no evidence that there would be some kind of sublingual absorption. So the buccal and gingival absorption is also it has a varying evidence of that. It goes through the first pass metabolism, hepatic metabolism, it is swallowed, it goes to the GIT, there is absorption into the blood vessels, then taken to the liver via the portal vein, and then metabolized in the liver basically, and then the metabolites are released into the circulation. And the minor part of metabolism also takes place in the GIT and the kidney. And 90% of oral morphine is converted into metabolites. And out of this 90%, 40 to 55% is converted into its metabolite called morphine 3-glucuronide, and rest 5 to 10% converts into morphine 6-glucuronide. And morphine 6-glucuronide, or M6G, is the active component that is responsible for pain relief. Okay. M3G as such is responsible for tolerance, development of tolerance, but that is excreted also, readily excreted also. So excretion is by glomerular filtration, and the basic M6G metabolite accumulates in renal failure, and this is the reason why we have to we have to reduce the dose of morphine while we are giving morphine to people with renal failure or any kind of renal disease. And at the same time, since its half-life is also increased, we have to understand how long we can continue with morphine for that particular patient. So, you must be also wondering how do we actually start morphine for people, for those who are opioid naive, who have not had opioids before. How do we start on them? Because being in cancer, I get people who have already had some form of opioids in the past. And that's the reason why introducing a strong opioid to a patient is not very tricky. But for pulmonologists, I'm sure that you may not be getting many patients who would already be on a weak opioid or another strong opioid for that reason. So we need to understand the need for strong opioids, basically morphine. So we do a trial which is known as the intravenous morphine trial. So we use injection morphine sulfate, and at the rate of 1.5 milligrams at an interval of 10 minutes. And we have to keep in mind what would be the immediate side effect that we expect out of intravenous morphine if the patient was never on opioids, okay? If the patient is opioid naive. So for that reason, we need to understand that the immediate side effect that would be expected is vomiting. And that is the reason why we need to put our patient on a pre-med, which is injection metoclopramide. Metoclopramide is a prokinetic, and it is a centrally acting agent which reduces the vomiting. Okay, so use metoclopramide, give an injection of metoclopramide at 10 milligrams intravenously, and then start with the IV morphine trial. What do we expect out of the trial? The endpoint would be satisfactory pain relief or drowsiness or sleepiness, whichever is earlier. Okay, so you expect that the patient after the trial would actually give you a satisfactory pain relief. For example, if you ask for the intensity कि आपको 1 से 10 के बीच में कितना स्कोर है अभी, then the patient would actually tell you that पहले मेरा 10 था, अभी मेरा 2 हो गया है. So you can see the difference that the patient has had. Okay. At the same time, you must also consider the fact that all pains generally do not respond to strong opioids. Okay. And even if you start with a morphine trial, or you think or assume that morphine is the only medication that will take care of the patient's pain, the patient may not actually tell you that I have had complete pain relief. Instead, he will say that I'm extremely drowsy, but my pain is all the same. So the end point of a morphine trial, IV morphine trial, is either satisfactory pain relief or drowsiness. And we take that particular endpoint, whichever becomes earlier. So this is a small chart that we generally use for starting IV morphine trial. And, for example, say you started your trial at 10 a.m. The pain score of this patient was 10. And at that point, he was not drowsy. So you give 1.5 milligrams of morphine. So generally, morphine comes at a strength of 15 milligrams per ml in 1 ampule. So you have, in order to give 1.5 milligrams, you have to dilute that particular ampule with another 9 ml of distilled water or normal saline, so that you get a strength of 15 milligram in 10 ml of dose. So from that, you take 1.5 ml, you slowly give that medication as in the intravenous route. You wait for 10 minutes and then you ask the patient about the pain score. आपका पेन पहले से कितना है? Maybe at around 10:10 a.m. he will give you a pain score of 7. Okay. Similarly, you continue repeating the dose every 10 minutes, and perhaps at around 10:30, the pain reduces to a score of 1. Okay. And at that point of time, you generally stop the dose, because is already, from 10 to 10:30, you have actually given 3 doses of IV morphine of 1.5 milligrams. Okay. So now, how you calculate the total dose? So you've given 4.5 milligrams IV morphine, and that has a good pain relief. So how will you now convert IV morphine to oral morphine? So always remember that oral morphine and IV morphine strengths work, are the work of both the morphine formulations are similar. So if you have calculated this to be 4.5 milligrams, you can actually start oral morphine in the nearest dose, which is 5 milligrams, that too orally. And then since, oral morphine will work for a duration of 4 hours, that is the reason why we give that in an interval of 4 hours. We had given IV morphine at an interval of 10 minutes. So IV morphine would actually work for 10 minutes, at an interval of 10 minutes. At the same time, oral morphine will actually work at an interval of 4 hours. So the strength will be the same, but the duration of action will be longer. As I told you earlier, since it is hydrophilic, the duration of action of oral morphine is longer than the IV morphine. So you found out that 4.5 milligrams of IV morphine has taken care of the pain, reduced it from 10 to 1. So since we need a continuous analgesia for the patient, we will have to advise 5 milligrams of oral morphine every 4 hours for 24 hours. Okay, and you need to continue this for the time. And at the same time, review the patient every time he comes to your OPD. Ask about his pain score. आपका अभी पेन कैसा है? कितना कम हो गया? पहले से बढ़ गया है क्या? बीच में आ रहा है क्या? Everything depends on the subjective response of the patient. Okay. So you start with 5 milligrams of 5 milligrams generally for opioid naive patients, and 10 milligrams for those already on weak opioids. You may consider starting a trial also. And opioid naive patients, I would actually say those patients have never taken opioids before, but at the same time, patients who may have been in opioids before, but have not taken opioids for the last 30 days or 1 month can also be considered opioid naive patients. So I come to an interesting drug called fentanyl. It's a fancy drug. It is a expensive medication for basically for patients where I work. My patients are all poor, so I need to give them morphine only, but then I need to know about fentanyl also. Fentanyl has some good amount of advantages also. It is less constipating than morphine, and it may be useful in subacute bowel obstruction because it is less constipating. It sedates less than morphine also. And as I told you, fentanyl does not accumulate in renal failure or hepatic dysfunction. And that is the reason why we prefer fentanyl in renal failure and hepatic dysfunction. It is lipophilic as compared to morphine. That is why, when we use transdermal fentanyl patches, it forms a depot underneath the skin, and from where the drug is actually distributed slowly over 72 hours. Okay, so that is why the effective analgesia has to reach by, between 8 to 12 hours, because it needs time to get absorbed and reach peak. And that is the time period, 8 to 12 hours. So whenever you, advise fentanyl patches for your patients, you need to consider the effective analgesia period. And till the time fentanyl starts its work, you must cover that particular period with oral morphine. Okay. All right. Then we come to morphine side effects. I believe you all know about opioids side effects, mainly constipation, nausea, vomiting, sleepiness, tiredness, itching and pruritus, dry mouth. There may be urinary hesitancy also. Constipation, about 95% of our patients, they last long. That is the reason why we need stimulant laxatives, and that is it's because of the fact that morphine or opioids causes, a temporary paralysis of the gut. And that is the reason why you should never advise bulk forming laxative. They are contraindicated and they will precipitate obstruction. Nausea and vomiting occurs in around 1/3 of our patients in the first few days, but always remember they are self-remitting. Always reassure your patient, and at the same time, use drugs that act on the chemoreceptor trigger zone. And those are D2 receptor antagonists. Basically, we use metoclopramide. The drug of choice is, of course, haloperidol, but metoclopramide is also considered. Sleepiness and tiredness occurs in 1/3 of patients on initiation. So that is also self-limiting. Pruritus or itching is a very irritating kind of a side effect that few patients might have. And we generally do not use agents like, histamine blockers or something like that, but we use drugs like ondansetron. Ondansetron is a serotonin 5-hydroxytryptamine 3 receptor antagonist, and that actually blocks the action of pruritus centrally. So we use itching or pruritus induced by opioids can be taken care by use of ondansetron. Toxic effects are delirium, myoclonus, and drowsiness. Coming to something which you as pulmonologists will be, looking forward to is regarding pain in respiratory illness. So, in COPD, you can actually see a review article here, which has shown that, symptom prevalence in advanced COPD, pain occurs in 34 to 74%. Okay. And there were 3 symptoms that were very frequent and universal. Okay. Fatigue, breathlessness, pain. Despite their high prevalence, these symptoms unfortunately face under-assessment and under-treatment also. Many other evidences are there which have shown similar, results, similar things. Pain in COPD usually felt in the chest. They may have a musculoskeletal or pleuropulmonary origin. Basically, the causes are postulated to be subcostal pain due to diaphragmatic and intercostal muscle fatigue, rib fractures relating to cuffing or corticosteroid-induced osteoporosis, because in COPD, we use a lot of corticosteroids for, which might actually lead to osteoporosis. And then pleural inflammation caused by infection. ILD is a dreaded disease in respiratory illnesses, and the main pain location in the patients with ILD was shown to be the chest, joint, and the limb in this particular paper. Main causes of chest pain, they although remain unclear, but they can be related to the pulmonary loss of elasticity of a parietal pleura, the bronchial fibrosis, which has actually, started setting in, thoracic vertebral deformity also because of the restricted, normal respiration, costotransverse intervertebral arthropathy, activities related to breathing and postural dysfunction. Patients with pain in ILD suffered worse quality of life and psychological deficits like symptoms of anxiety and depression. I can relate to it because very recently I had one of my very close relatives who passed away in ILD. So certain myths and facts that you must know is that opioids will cause respiratory depression. Actually, patients take their medications by mouth combined with the normally gradual dose, ensuring that respiratory depression is unusual. And, whenever respiratory compromise occur, there is an alternative explanation which must be looked into, such as pneumonia, pulmonary embolism, cardiomyopathy, co-administration of another sedating medication, such as benzodiazepine. In fact, there are certain papers, and there is an RCT which actually says that opioids, improve on the general feeling of respiration or air hunger. NSAID should be avoided in COPD because of the perceived risk of precipitating bronchospasm. The fact is, the existing evidence suggests that paracetamol and NSAID should be used with equal care in COPD patients, but that for use in pain at the end of life, benefit from ibuprofen and paracetamol is likely to outweigh any harm. So these are the evidences that are there. The myths should always be removed. Look for the new research that are being conducted in many of our patients to, give them the best benefit that we can. Thank you so much for a patient hearing. And as promised to Rajlakshmi, I have actually completed my session in 1 hour. I hope I'm able to explain some bit of management of pain to all of you. And from now on, you will not hesitate to use opioids or other pain medications for your patients. Thank you so much.
Thank you so much. Raju, am I audible?
Yes, ma'am.
Yeah, okay. Thank you so much, Sanghamitra. This is a very vast topic which we usually cover in 4 sessions, probably. So we have touched upon the most important aspects in a very, I think, in a very clear way, emphasizing on the very important facts. Thank you so much. I'm not wasting time. I'll quickly go to the participants, whether they have any questions, especially in rotation, titration, because those areas are very important. I'll just wait for 2 minutes for any comments or feedback. Maybe it is good to know whether you have been using this, we have heard about this kind of titration and conversion from fentanyl to morphine, morphine to fentanyl, IV titration. It will be good to know from you. I can see a question in the chat by Dr. Suresh. Dr. Suresh, we'll definitely help you in procuring morphine for hospital care. After this course, we have another team called facilitation team who will be working with you for helping you with necessary documentation, convince your administration, and make it possible that you have access to morphine in your hospital. That's something that we do for all the participants. So we are there for that. Sanghamitra, would you like to answer that question a little bit about the process so that it is?
Okay, so it's not really very hard to procure morphine for hospital care or clinics. The only thing that you need to do is, take an RMI certificate. So RMI is Registered Medical Institution. Nowadays it's, thanks to Rajgopal sir and other stalwarts of palliative care in India who have actually made this thing possible. You need to approach the drugs controller of the state. He's the single window who's going to give you, all the formalities for procuring morphine. There need to be a in charge of that particular registered medical institution where the morphine is going to be used. You have to fill up certain forms which are quite easy nowadays, and it is like it is like a banking process that you have certain amount of morphine with you. You have utilized some of them. You need to show your documents to whom have you given and how much, etc., etc. And then at the end of the year, you show a balance of how much is left. So it's not a very difficult process as of now. I think, yes, as Sridevi said, Pallium is always there to help procure that for you. Yeah. So
There are more questions for you.
yes,
Yeah, I think
totally.
sorry.
Yeah.
The analgesics on for motor neuron disease or neuromuscular disease. And there's a continuation to that question by Dr. Gayatri again, that will it worsen any of these illnesses?
So, Dr. Gayatri, the pain management principles generally remains the same for any kind of pain. The point here is that you need to understand and diagnose what kind of pain it is. Pain doesn't actually see the disease. Pain is a symptom that is being exhibited because of the underlying disease. So that is the reason why it, there are, as I told you, in renal diseases, you would hesitate to use morphine and you would choose fentanyl for obvious reasons. So similarly, you'll have to have certain amount of knowledge about pain medications for their usage in particular diseases also. But opioids will not really worsen NMD or MD for that reason. Yes. Okay, so there is one question. Can you please explain about the role of morphine in breathlessness in respiratory diseases? Absolutely. Morphine is a very important and a wonder drug that can be used for breathlessness. The exact mechanism of action is not known, but it reduces the mechanism that is centrally related to increase in breathlessness. It reduces the air hunger of these particular patients, and I have also read somewhere, I still don't remember, it must have been a textbook of respiratory diseases, where they have mentioned that certain mu receptors are also present in the respiratory tract, and they also act via those receptors, mu receptors, and thereby reducing the air hunger. And while taking care of cancer patients suffering from breathlessness due to lung cancer or any other diseases where breathlessness is the main symptom, we generally use a very low dose of morphine. For example, if the patient is not on morphine, say the patient is opioid naive, then we start from 2.5 milligrams of oral morphine at an interval of 6 hours, or at an interval of 8 hours also. At the same time, if the patient is already on morphine and we want to, improve his breathlessness, then we have to just increase that dose by 30%. Okay. Suppose the patient is on 5 milligrams of morphine every 4 hours, then we just need to increase its dose to around 7.5 milligrams every 4 hours. So that is also going to take care of the pain as well as the breathlessness. Yeah. Okay. So.
I lost the connectivity in between. I hope some of the questions were addressed in the chat.
Yeah. So, all right. So this is a very good question that has come up. Is the IV morphine trial compulsory prior to starting oral? I can't say it is compulsory. It is, I generally would want to go for an IV morphine trial because that actually gives me a clear picture of how much pain the patient has. Number two, how much, what kind of pain the patient has, and whether the pain is responsive to morphine at all. Let me tell you that only 45% of pains are responsive to opioids, responsive to morphine. So please do not have this idea that, okay, we are giving morphine, so 100% pain relief hoga. It's not like that. That is the reason why I really would want to go for a IV morphine trial. And at the same time, it gives a good feeling to the patient because I would want to start IV morphine trial in a patient who has a acute pain exacerbation and has come to me. So I want to give that relief to the pain by putting the patient on IV morphine trial, finding out the responsiveness of pain to that particular dose of morphine, and then converting that to oral medication, oral morphine. So that's like, okay. Okay. So Rajam is actually there. So Rajam has suggested medications for MND, and I completely agree with you. You can try baclofen or magnesium oil. So baclofen is a it can be actually combined with opioids for MNDs. Yes.
I have, Sanghamitra, thank you for this talk. I always end up learning more whenever I listen to pain talks because it's always nice to keep refreshing. So I hope my fellow pulmonologist colleagues also have liked it. Now I have sent a couple of papers on treatment of ALS, MND to Rajalakshmi, and the amount of morphine that actually sometimes does go in the last few days of patients with ALS. I have also sent a paper of pain in COPD because there was a question about pain. So Rajalakshmi, I request you to send it all. I think she'll do it tomorrow. It's just important because I think as doctors and pulmonologists, like last week, we are so focused on treating physical pain and then gauging the response to morphine with physical pain. Not all patients have pain as in, like a muscle pain or a fracture pain or a bone pain. There is a lot of pains that our patients go through with, especially with chronic advanced lung diseases. And we just need to, I know it's not easy in your busy OPDs to keep asking every patient about, but if you see a particular patient who is not responding to your regular treatment, not looking right, withdrawn, always looking sullen or sulking, you should approach the patient with what else is bothering you. Because believe me, sometimes the situation at home, psychological issue, the spiritual pain, ki why have I deserved to get this illness? So all these things contribute to the overall emotional status of the patient. I know it is not in your bandwidth to treat this, but acknowledge it. If you address it, then you can send it to psychologists, you can send it to your palliative care team, or you can even send it to a GP that the patient is following up, so that at least they can have some conversation with somebody they're close to and open. So it's very, very important. Sorry, I'm not able to put my video on today. There's some issue with my bandwidth, but I thought it was important to share these papers with you, which Rajalakshmi will. Over to you, Sanghamitra and Sridevi.
Thank you, Rajam, for that very wonderful thoughts. And it's going. I mean, your advisors have always worked with our, with everybody. So,
Kind of you.
okay. So, okay. So there is another good question that I've come across. Do we have time for questions?
We have one case presentation.
Exactly. So maybe I'll just take this last question, right? Yeah. So is there a possibility that the pain is so severe that neither morphine nor fentanyl can control it? If so, there anything else we can do to decrease the pain? So that means, when you are using morphine, I was talking about, finding out by using IV morphine trial, whether the pain is responding to opioids or not. The question says that pain is so severe that it neither responds to morphine nor fentanyl. You have to see whether you have given the right dosage to the patient or not. These are the situations where, we need to do a IV morphine trial, because this will give us the correct answer of using even morphine or fentanyl. There will be situation where you have actually found out that the patient is responding well to 10 milligrams of morphine every 4 hours. But in your next visit, the patient actually comes in severe form. Okay. At that point of time, you will escalate the dose of morphine, oral morphine. But you keep on escalating. The patient actually says, no, nothing is working out. I am now slowly becoming drowsy. When that side effects start taking over, you can actually say that perhaps morphine is not the right medication for this patient. The next step that you would want to do is a reversal of opioid. For example, when I showed you the table, giving you the potency ratio of morphine to other pain medications, you understood that fentanyl has a more potency than morphine, right? And here, when the patient is not responding to a certain amount of escalation of oral morphine, you can always do a opioid reversal. And that reversal would mean that you are stopping morphine and you are starting on with another more potent opioid, which is fentanyl. Now the question is, if the patient is not responding to fentanyl, you must consider one thing. Is the patient showing signs of adverse effects or more of the side effects, despite the fact that he is not responding to the dose that you have given? If he doesn't have side effects and he's not responding to the amount of medication you have advised, that means it is under dosage. you have to increase on the opioid dosage. And please do not, be fearful of increasing the dose, because morphine doesn't have a ceiling effect. Okay. You can increase the dose, you can escalate the dose, titrate the dose to an amount where the patient generally will respond if the pain is responsive to opioids. All right. I'll tell you an example. Suppose there is a patient who has bone pain, okay, and we have started him on morphine, but the patient now has started showing side effects of morphine rather than responding to morphine. We stop the morphine then and there, because our desirable effect is pain relief and not side effects. We are not getting the pain relief as desired. We are getting side effects. So stop the morphine. Bone pain is not responding to the morphine. So we need to devise our strategy of managing the pain to something else. I will not go into much details, because then we will go into managing difficult pain session. I don't know whether Sridevi has included difficult pain management here for pulmonologist.
No, we don't have a session on difficult pain management for this.
I think this particular madam is, I think she's asking about difficult pain management. So I am there, you can actually call me and we can chat about it later on also. Yeah.
One question to Dr. Pavitra. We were supposed to take Dr. Pavitra's case presentation. I think
It's slightly overshooting time. How would you like to go about it, Dr. Pavitra? Would you like to take it for another session, or should we continue with that?
I don't mind presenting it now, ma'am.
Sorry, I couldn't hear you.
I can present it now if there is enough time. I don't mind presenting it now.
Okay, yeah. I think we can go ahead with the case presentation. And if anyone feels that you have any other commitments post 8 o'clock, we can just keep it very, very brief. Please go ahead, Dr. Pavitra.
Good evening, everyone. I'm Dr. Pavitra, MD General Medicine. Can I just go to the next slide? Had a patient, 74 years old male, with a diagnosis of non-small cell lung cancer, squamous cell carcinoma with metastasis to the cervical spine, involving C7 and C8 vertebra. This is the chronological order, but the patient actually presented with the worsening neck pain radiating to the right hand for the past 6 months. So on further talking to the patient, he also had complaints of persistent productive cough for the past 1.5 years and difficulty in breathing associated with these. He was all right 1.5 years back. Then he had developed productive cough, which was gradually progressive when enough the difficulty in breathing has progressed to an extent where he is not able to perform his daily activities. And there was loss of weight and appetite. Recurrent fever history was present. The neck pain was worsening and there was little loss of power. He had little difficulty in holding objects. The power was slightly reduced in the right hand. He was a smoker with 40 years 40 pack years of smoking history. When he presented, yes, the next slide. He presented to the OPD. His blood pressure was 140 over 80 mmHg. The pulse was 96 beats per minute. Respiratory rate was 26 per minute, and saturations were 88% on room air. Respiratory system examination, there was decreased breath sounds in the right mammary area. Wheeze and fine respiratory gaps were heard in the right inframammary and infraaxillary areas. Nervous system examination, the power was slightly reduced in the right upper limbs. The triceps reflex and the finger flexion reflex were new, and the sensations were decreased on the ulnar side of the arm, forearm, and the hand. And tenderness of the cervical spine was present. On symptom assessment scale, the Edmonton symptom assessment scale showed severity of 56 by 90. We got all the routines done. On CT, there were homogeneous opacities. Next slide, ma'am. CT showed non-homogeneous opacities in the right middle lobe, and the MRI spine showed hyperintensities noted in the C7 and C8 levels. So we advised the bronchoscopy, which showed an endobronchial mass, and the biopsy was taken. Histopathology confirmed non-small cell lung carcinoma, and immunophenotyping showed positive for EGFR and KRAS markers. And PET, it showed metastatic lesions at C7 and C8 levels. And the patient was put on controlled oxygen therapy and rest to reduce the symptoms. And he was referred to a cancer center because the patient didn't want any treatment for cancer or no surgery, or he didn't opt for any surgery or chemotherapy. Ma'am, can you please change the slide? Yeah. So coming to the psychosocial aspects, patient was aware about the diagnosis and to some extent prognosis also. The family members were aware of complete disease progression, and they had complete acceptance about the death. So the medications which were given to the patient were, they started off with morphine, but the patient's symptoms didn't subside. And the main concern of the patient was to die at home. So we didn't want to stay in the hospital. Because the symptoms were not subsiding with morphine, they changed him over to fentanyl patch, and injection Rantac and tablet gabapentin were put for the neuropathic pain. So the main concern is he was worried about the symptoms because they were worsening and was not responding to medications. And the family members, they were unable to see the patient suffering. He was not able to perform his daily activities. Next slide, ma'am. So coming to the summary, so 74 years male, smoker with complaints of difficulty in breathing, which was progressive, leading to physical fragility. Persistent productive cough was present, recurrent episodes of fever, weight loss, appetite loss, and worsening neck pain. Workup was done and diagnosed as non-small cell lung carcinoma, squamous cell carcinoma with metastasis to cervical spine, C7 and C8. Patient refused treatment for carcinoma. The family was concerned about patient suffering and the quality of life. So the discussion point, main concerns of the patient was physical fragility and psychological distress about the pain, and he's not able to perform his activities. And he feels that he's being a burden to the family members. And the main concerns of the family were patient is suffering and the quality of life of the patient. Oh. Thank you.
Thank you, Dr. Rajan, can you and Sanghamitra, can you take up the questions so that?
I think Sridevi, let the audience actually start answering these questions, because they have now come to know about managing pain and the basics. So maybe we can have their inputs about how they are going to how this could have been improved, and yeah.
Sure. We'll wait for your comments. You can either type it in the chat or we are happy to hear from you. Anyone? Because Dr. Sanghamitra was mentioning about managing pain today, and last week we heard about how to integrate palliative care to improve symptoms, or when to how to integrate palliative care in such patients. So there is one question or comment from Dr. Gayatri. Will nerve blocks help in this case? What about others from your experience? Do you think nerve blocks will help? What is your experience on that? Or what else can be done? Dr. Gayatri, would you like to unmute and speak? Like what was there in your mind? If you can unmute and speak, that would be great. Any other comments? This is very awkwardly silent. No comments and no questions.
There are some questions on the chat, Sridevi.
I think there is only one from Dr. Gayatri. Did I miss? No. Only about the nerve block. So Sanghamitra was asking which nerve block and why, then she responded to it.
So can I comment, Sridevi?
Sure, please.
So the diagnosis says that it is a small cell lung carcinoma with metastasis to cervical spine. Okay. So we have to understand, the effects of metastasis. When we are speaking about metastasis to the spine, to the vertebral column, we need to understand two things. Number one, the metastasis is actually pressing on the roots of the cords. And at the same time, it also has a component of bone pain. Okay. So only, taking care of the nerves by means of a nerve block will not 100% remove the pain. Okay. So perhaps we will have to use a three-pronged approach for this patient. Since the patient complains of severe pain, we need to understand that the bone pain will be responding to NSAIDs plus steroids. The steroids are known to reduce the peritumoral edema, and at the same time, we need to introduce an opioid for this patient. Now, I can see that fentanyl was started, but the presentation doesn't give us a proper picture of how much fentanyl has been given, or at what point of time fentanyl was given and what point of time morphine injection was given. So we generally do not have the information out here. Okay, so if I have this patient coming into my OPD, I would generally start a multi-pronged approach of starting the patient on oral morphine. At the same time, dexamethasone, oral dexamethasone to reduce the peritumoral edema, and at the same time taking care of the bone pain that might be transmitted by the vertebral bodies. And gabapentin is definitely a good choice of adjuvant drug because it takes care of the neuropathic pain also. I will really not advocate the use of fentanyl at this point of time, unless and until we have a patient who is actually showing, renal or hepatic impairment. The reason behind this is that I will not be able to titrate fentanyl as and when required, but I can always titrate morphine tablets, oral morphine. 5 mg बढ़ा दिया, 2.5 mg कम कर दिया, escalate कर दिया, starting off with trial also. But I will not be able to do that with fentanyl. I want to introduce fentanyl at a point where the baseline has been reached, and the patient says that my pain is now maybe 2 on 10, and I really don't want to eat tablets every 4 hours. Okay, at that point of time, I would actually convert the total dose of morphine to an equivalent dose of fentanyl patch, expecting that the fentanyl patch will, provide the same type of relief to this patient. So that is my take on this particular case.
Just to add one more thing that Sanghamitra said, I think amongst the private physicians, fentanyl patch is very, very popular. It's also, I think, the hard work of the pharma companies. Unfortunately, we must remember that it is very expensive compared to morphine. In a tropical country like India, people sweat. Not everybody can be kept in an air condition. And therefore, when you put fentanyl patch, there sometimes we really don't know the amount of circulating morphine. Third thing, when you put the fentanyl patch, it takes about 8 to 10 hours for it to start activating. So you really don't know how the patient is going to be for that 10 hours. And 10 hours is a long time to continue to suffer the pain. And lastly, when you remove the fentanyl patch also, there is some amount of circulating opioid. So you really don't have information about the level of circulating opioids to be safely increasing or decreasing your morphine medications. While if you give oral or subcutaneous, it is in your control that you have given this much, you can wait and watch and give more or skip the next dose, etc. So the control and the safety and the expense of fentanyl and vis-a-vis morphine is something we need to remember. It's not that when you stick the patch, it starts doing its work. It takes about at least 8 to 10 hours. So I think that's an important point, and you also end up spending much more than morphine with morphine. And I don't want to go more than this because we are past time. So, Sanghamitra, is that fair? I mean, what I said?
Absolutely, absolutely. I completely agree with you. Absolutely.
Thank you so much, Raju and Sanghamitra, for the session for today. Thank you so